So always a disclosure, unfortunately, I do not have any conflict of interest at the moment, all right? And then all pictures, graphics, for those that are stricklers, that are not referenced, I own them. I usually sometimes take some of my funds and then I pay for pictures and then I can use them for my presentations. So the objectives, we're gonna review some of the traditional agents to manage some of the psychiatric disorders, kind of more of a review. And this kind of, I usually like to have this because it kind of sets the tone for some of the newer medications and how they relate to the future of psychiatry or what their proposed mechanism of how they may be better, sometimes and sometimes not, with some of the traditional medicines. One of the things people have been asking more about is the cardiovascular adverse effects. Take a closer look at genetics. And then we'll talk a little bit more about some of the kinetic variations that have been, that people have been asking questions. So overall, for the mood disorders classifications, I'm going to mostly go ahead and focus on major depressive disorders generalized and PTSD. I always like to have this slide because generalized anxiety, social anxiety, and panic disorders tends to be your traditional anxiety disorders. PTSD and OCD are not really considered anxiety disorders anymore. They're considered anxiety-related disorders. And this actually plays a role with the type of agents that we use. So with major depressive disorder, we have middle-aged females, divorced, separated, widowed. This is kind of, it used to be more separate. Over the last 10 years, the gap is actually closing.
This one, a co-host.
Also tends to have more comorbid psychiatric disorders. I always say genetic cocks the gun and environment pulls the trigger. So you're born with a genetic predisposition, and then depending on the psychiatric and depending on the environmental stressor that you may have, may be how much of your psychiatric illness that may manifest. So if someone has a high genetic predisposition, you may just need a small environmental stressor to trigger depression or some other psychiatric illness. That's why sometimes people say, it's like, well, I don't understand why this person ended up getting depressed. Just having something was small or was anxious or small. Well, I think to those that, well, I've been completely healthy all my life and I eat healthy and I watch my diet from the day back there. I tend to eat more on the left-hand side with the salads and the fruit. And somehow I still got placed on atorvastatin for high lipids. And then I got other people that are just going to town on the bacon and then, you know, no atorvastatin lipid management needed. It's just you get what you get sometimes. So age of onset, typically with anxiety and depression, it can occur at any age, but typically we see this in the mid-20s. Because this is the first time that you're getting into college or finishing college, you're having your first position, your first job of employment, you may be having your first significant relationship. Some of these things may be failing. Perhaps you've had postpartum depression could play a role. So you're having a lot of environmental stresses that are occurring during this time. Prevalence tends to be about 10%, more or less, over a year and during the lifetime. So usually one of the questions I normally get when people start antidepressants for depression or anxiety is, well, how long do I have to be on the medication? So typically, the first time, I say about a year or so. Some people will go less, about 6 months, but typically about a year. After your second episode, about 2 years. And then after the third episode, you pretty much have a 90% likelihood that you're going to have another relapse. I like to think of it as the 3 strikes you're out, and more than likely after the third episode, we more than likely will have to treat lifelong. And there are studies to show that patients that are treated effectively with antidepressants tend to have healthier lifestyles and less comorbidities, and even a higher life expectancy than those with depression that go untreated or suboptimally treated. Suicidal risk is about 20% in your lifetime. Comorbidities, about 85% of patients with major depressive disorder will have some other comorbidity. Tends to be about 50% of them may actually have a comorbidity of anxiety, which is sometimes when we start antidepressants, you might see an increase in anxiety. And then that kind of leads to a patient discontinuing treatment. And I'll talk more about that as we go through the next 4 or 5 hours. And then always treat the medical underlying issue. Sometimes people need to get worked up. It could be medications, it could be hypothyroidism, other comorbidities, cancer, that need to be ruled out before we go ahead and jump to psychiatric medications. So the pathophysiology, we have underactive prefrontal cortex. This is your area of cognition and thinking, even emotional, even a little bit of emotion, like this creativity and cognition. And then you have the Brodmann area 25, that's a fancy word to pretty much focus on your limbic system. They're going away from this Brodmann's areas, but I think of 25, you're young, you're having a lot of fun. Hopefully you're still having fun now, all right? Especially if you're in Vegas, but that tends to be more of your active settings. And then the amygdala is mostly for your emotional states and how you respond to stressors. So these are images. You can see how sometimes I have people, and sometimes even students in pharmacy programs and even nursing programs, assistants that sometimes are like, well, I think it's all in your head, really don't believe in mental health. Even in some other countries that I've gone to, when I've discussed this and taught there, we have medical students that are saying, now we really don't believe in mental disorders. So this is kind of has been, I think I've been using these slides for almost, this picture for almost 15 years now, maybe longer. That basically showing your serotonergic function and how it compares between the left, which is a healthy brain, versus the right, which is somebody with major depression. So you can see, you know, here in the cortical area, you're less activity, and you can even see some of your wider gaps. So pathophysiology dysregulation for depression. Basically 3 neurotransmitters. You have serotonin, dopamine, and norepinephrine. Your predominant one is going to be serotonin. Serotonin, if you want to put a number to it, think about serotonin is about 70%, all right? And then dopamine and norepinephrine take over the other. So I always say a lot serotonin, and then some dopamine and some norepinephrine. Your clinical presentations, I'm sure you've seen this before, the SIGI caps. So you have your sleep. Some people lose sleep, some people can't sleep. Those that typically have some issues with not being able to sleep have this anxiety comorbidity. Loss of interest, increased guilt, no energy, some difficulty concentrating. Appetite could fluctuate, as well as your psychomotor agitation or retardation. Those that have anxiety tend to have a little bit of a psychomotor agitation, and then suicidal ideation. Poor hygiene, weight changes. A perfect example of your hygiene is sometimes when you look at Alzheimer caregivers. So all caregivers for patients with Alzheimer's disease, they tend to be at a high risk for depression. And sometimes over time, when you start seeing them, you're seeing them more disheveled. You're seeing them, they're not showering as often. So sometimes we focus so much on our Alzheimer's population, that we sometimes tend to forget about the caregivers. Right. So I like to always bring up this irritability and anger that sometimes get missed with depression, because when we're thinking about depression, we're thinking about the sadness and the crying, and that tends to be more with females. Men tend to display more of the irritability and anger and short temper. So sometimes those are being thought as just anger outbursts but those are symptoms of depression that is more often seen in males than they are in females. I'm not saying that females don't get irritated and angry as well, they do, all right? And men also cry and so forth, but sometimes we tend to miss these symptoms. So to summarize the DSM-5, basically you gotta have at least 5 of these symptoms. They have to be happening every day for at least 2 weeks. And most importantly, they have to create a problem with your activities of daily life. So if they're impacting your job, if they're impacting your relationships, then that's when you need to start considering if we're going to be able to treat. With suicide, this has been increasing in the news. And we're also talking about whether the antidepressants can increase. So there's a black box warning for the increase in suicidal ideations in those younger than 24 or 24 and younger. We'll talk more about that. But overall, with your suicide assessment are there ideations? Is there substance use that has increased? Do they feel any purpose, any type of anxiety, agitation, this feeling of trapped, hopelessness? And then we go back with withdrawing, anger, reckless behavior, and then mood changes. On the flip side, with anxiety, we tend to have an activation of your sympathetic nervous system, and it's this fight or flight response. And therefore, you're getting increases in your heart rate, blood pressure. There's a little bit more of sweating and muscle tension. When you look at the comorbidities, anxiety and depression almost coexist with a 50% overlap. So if you imagine 2 big circles that kind of intersect, one circle will be depression and another one will be anxiety, and those circles are intersecting, about half of your patients will have both symptoms of depression and anxiety. Right. With generalized anxiety, again, the gap is closing. Socioeconomic, stressful events. There is a family link. And with anxiety, it's interesting because with anxiety, some of the studies that are looking at the family history, that if someone in your family has anxiety, then it might be related to genetically. There are some studies that also suggest that it's also environmental, because kids are mimicking how their parents are behaving and reacting to stressful events. So, at least with my grandmother, it was always like, I would call and say, hey, how are you doing? And her response always was, oh, I'm doing good for now. There's always this ambivalence that somewhere along the line, something bad is going to happen. And then if whatever big thing happened was like, oh, you got this negative consequence, I have a reason to be worried. So those things from a family and culture are sometimes prevalent that tend to perhaps exacerbate this genetic link with that genetic cocks the gun environment pulling the trigger phenomenon that we see. Prevalence, adults 3%. Clinical course, depression, full remission rates are low. And this is extremely important because when you're talking to a patient expects complete resolution of symptoms. And sometimes those expectations are impossible. You're never and rarely are ever going to get rid of all of your anxiety symptoms. It's just not going to happen. So it's very important that when you start off talking with your patient, you come up with some reasonable expectations. So, for example, you may have a patient that is deathly afraid of driving. They don't want to drive, or they're deathly afraid of going to a big mall with a bunch of people, or to go to Target or Walmart, or just where there's a lot of people. And we start them on treatment. Now, we may never be able to get them to drive on the highway, but at least we can get them to be able to drive through the local streets to get to where they want to go. Perhaps we may never get them to go to these big malls and so forth, but maybe we can get them to go to smaller department stores, or have them go when it's a weekday, early evening, where there's not going to be a lot of people. You may never get someone to go to the movies on a Friday or Saturday night. Maybe you can catch them on a matinee during the week. So the pathophysiology, it involves a lot of other type of systems, a little bit more than just depression. But overall, what I like to remind people is that there is a dysregulation of your hypothalamus, pituitary, and the adrenal cortex. So your HPA axis is dysregulated. Of course, you have other systems where you have impairments of your dopamine and norepinephrine function. It still kind of relates with your HPA dysregulation. So there is a serotonergic model that is what we mostly follow. This is following a little bit, kind of changing over time and evolving, but you have again, a dysregulation of your serotonin transmission. What ends up happening is, in depression, you simply have low serotonin in your synaptic cleft. In anxiety, you actually have the same thing, which is why you see this comorbidity. So you still have low serotonin. What happens with anxiety is that I'm going to go back a little bit, throw back to pharmacology. Your postsynaptic receptors, they're being starved because of this serotonin deficiency. So they start to create more receptors. So think of it as, how many went out to eat dinner last night to a really good restaurant? No? Okay. All right. Did you have to make reservations? No. Okay. Why? Because it's the weekday. Maybe you went a little bit earlier and there's no one. So there was probably everybody come on in. Extra doors. You might have had some coupons to get in. That's kind of like, no dress code. That's kind of like what these receptors are doing when there's no serotonin. Everybody come on in. There's no restrictions. What all of a sudden happens is the weekend hits. We got a couple of more thousand people that come in, and now you need reservations. You need a dress code, and it becomes more restrictive. So those neurons, when you get an environmental stressor and you get this surge of neural transmission, those gates are not controlling what's going on, and they get this surge, which is what leads to these anxiety symptoms. When you start medication, those medications is like you're always having people going to that restaurant. So it takes time for those receptors to regulate themselves. So the receptors that are regulating during anxiety, that takes more time. So that's why traditionally for depression, we say about 4 weeks, but for anxiety, it tends to be longer. Because for anxiety, it takes longer for those receptors postsynaptically to try to fix themselves. And that just takes more time. Right? Any questions with that? And I always say a lot of serotonin some dopamine, some norepinephrine. Serotonin, 80% of the time, if you have to guess, you can guess in psych, you can say serotonin 2A, and you're going to be about 80% of the time, you're going to be right. Okay? Then you can say 1A, and you'll get the other 10, 15% right. So for you, you're taking exams, 2A, and then if you got to add another one, 1A, and should be good. All right. With neuroimaging studies, there is activities. Basically, they're looking at how you receive information from the occipital lobe and how you're able to digest and rationalize what you're seeing in those stressors is impacting your behavior. So for generalized anxiety, it's got to be more than 6 months. It's worrying all the time. And again, there's a lot of this irritability, problems concentrating. If you notice, some of these symptoms kind of overlap with the depression. And this goes back to pathophysiology. From a pathophysiology standpoint, you still have low serotonin. And going back to this overlap I was talking about. All right. For PTSD, we tend to have a psychiatric disorder that you can, with a history of substance use, oftentimes, personality, you may have been treated badly as a child, socioeconomic status, educational level, minority groups tend to affect more females that leads to PTSD. History of trauma. However, one of the most common events for PTSD is the sudden, unexpected loss of a loved one. That has seen an increase post-COVID. So before it used to be sudden, unexpected sudden loss of a loved one. It started balancing out, and then right after COVID, that spiked up again. So incidences of PTSD have actually gone up. Most people are mostly focused on whether it's been economic, whether it's been some depression or just paranoia, but there has been an increase in PTSD, and there's also been an increase in suicide rates, especially in older adults. We don't talk about it, but it's what the data show. Oftentimes, there's also post-trauma, lack of support. Social interactions become dysfunctional. Genetics as well. PTSD can occur really at any age, just depending on when that stressor occurred. Clinical course is really unpredictable. It usually just decreases patients' quality of life, and females are less likely to recover, mostly because of the lack of support. For those with PTSD, 80% of them will have at least another psychiatric comorbidity. It could be depression, and it could be panic attacks. So another form of, you can have PTSD with panic attacks. You can have PTSD with social anxiety. Substance use disorder is about 50%, and about 20% will not just have suicidal ideations, 20% will actually have an attempt. So again, with the pathophysiology, PTSD involves cortisol. So cortisol acts as a negative feedback to control several systems, your sympathetic, your parasympathetic, but also your HPA axis. And what ends up happening is in PTSD, the HPA axis gets dysregulated. So even the cortisol levels are dysregulated, and they're not occurring the way they should. Also, your parasympathetic and sympathetic nervous systems also start to get dysregulated. And then that increases your PTSD response. So overall, just to kind of summarize, the hyperactivation of your autonomic nervous system goes basically in overdrive. You also have abnormalities in glutamate signals, and this can impact your ability to basically, I'm missing the word, how you process your emotions or how you process a stressor. And then this over time with this dysregulation can start to contribute to your hypervigilance, your disassociation. Your alpha-1 and alpha-2 are actually also involved, and they occur throughout your brain. They're responsible for that startle response that we traditionally know with our PTSD patients. It also affects your sleep, which is more like your prefrontal cortex related. And then also your cognition and normal response are also alpha-1 and alpha-2 are implicated with this process. All right. So with PTSD, greater than one of these exposure to actual or threatened death, serious injury, or sexual violence, by being able to witness it, learning that the trauma occurred to a close friend or relative, and the exposure through the media, it does not count unless it was work-related. The duration of symptoms is about greater than a month. Some people tend to have flashbacks. That's what we mostly tend to think about with PTSD, or you can have a lot of recurrent and distressing dreams. Overall, people with PTSD just begin to withdraw overall. Patients with PTSD over time, as they begin to withdraw, or they're feeling also that they're not having the emotional support or the support out there, can start to become very irritable, angry behavior. This starts to impact their relationships. It can also lead to reckless behavior, as well as that hypervigilance, exaggerated startle response.